Thank you, Mr. Chairman, and thanks to you and Senator Daines for holding this important hearing on telehealth. In South Dakota, we've long understood the value of telehealth. And the pandemic not only demonstrated the importance of telehealth, but also provided an opportunity to gather real data from its use. And I think that was helped illuminate even more the potential way in which we can deliver, particularly mental health services via technology. And while we've extended the telehealth flexibilities in Medicare until December of 2024, we need to work toward permanent telehealth policies in Medicare, such as those in bipartisan legislation that I've led with my colleagues, like the Connect for Health Act and the Telemental Health Care Access Act. Mr. Marotra, telehealth has proven to be an essential tool for providing access to mental health care. Unfortunately, I'm concerned that we enacted a policy in 2020 to require an in-person visit for telemental health visits in Medicare. Telehealth offers an opportunity to increase access to mental health, but an in-person visit requirement seems arbitrary and I think is going to make access even more inequitable. So last year, Senator Card and I led a working group as part of this committee's mental health care initiative to take a deeper look at how to improve telemental health care. Our legislation proposed removing Medicare's in-person requirement for telemental health services. From your research on telehealth, can you tell us more about the challenges an in-person requirement would have for patients seeking mental health services, especially for those patients in rural areas?
Thank you, Senator. I think it's a really important issue. So the one thing that we've done some work on is to try to understand how often does this in-person visit occur right now before a first telemental health visit. It's pretty rare. Less than 1 out of 5 times is there that 6 months in that 6 months in the current regs that we see a visit. I emphasize that point because it's going to be a big change in care if that in-person visit requirement goes into effect. And it's also clear to me that clinicians don't see that as really critical. And so I think that kind of data helps support, what a lot of us have spoken about, which is that this in-person visit requirement should be eliminated because I don't think it's adding value in the way, and it's also deterring people from using telemental health to access communities where there are no mental health specialists for them to see locally.
Yeah, thank you. Ms. Parisho, first I'm excited to hear about the work on telestroke. In 2017, Congress passed my legislation, the FAST Act, which eliminated the originating site restrictions for telehealth services to diagnose and treat stroke. However, as you outline in your testimony, additional originating site and distant site restrictions still exist, preventing patients from accessing care. During the pandemic, Congress suspended Medicare's distant site requirements for federally qualified health centers and rural health clinics. And in South Dakota, that enabled our health clinics to strengthen local access to care by building telehealth connectivity between remote, rural, and frontier sites. Could you discuss a little bit more, the importance of allowing federally qualified health centers and rural health clinics to serve as distant sites for telehealth?
Yes, thank you for that question. I've stated in my testimony that FQHCs and RHCs should be distant site providers because a lot of times they're that first touch of the patient when they're having a health crisis, and they support so many facets of healthcare in terms of the primary care, behavioral health, dental, and so on and so forth. So I believe it is very important for FQHCs and RHCs in rural areas to be distant site providers.
Okay. Let me just come back, Dr. Marotra, and if I could get you to comment a little bit on your research and the evidence that we now have on the quality of care provided over telehealth. Could you summarize that maybe a little bit?
There's been a lot of research that's been done on this topic, Senator, and so I think it's a really key point. In my testimony, I touched upon that some recent work that we've done, which has found that the greater use of telehealth by a health system or a clinic is associated with some improvements in health. And the one that I think is maybe particularly important is chronic illness medication adherence. It's very often our patients don't take their medications, and having that telehealth availability appears to have enough touch points and maybe increase their use of medications, which will have some long-term benefits. So I think it's a real key quality area.
And do you think all the now data that we have, largely through the pandemic, we got more sort of our real-life test cases for that broad adoption? And you have talked about, I think, in your testimony, too, that in past, some patients have worried about the quality of those visits compared to in-person visits. But with now just the volume, if you will, of the data available, and an opportunity to analyze the impact of that, particularly during the pandemic, how do you see, I guess I would ask, at least in the future, folks in government agencies that deal with these issues recognizing the value that telehealth delivers, and not just in making available mental health, but also, or mental health services, but also the quality of those services?
Yes, Senator, I fully, and this was emphasized by other panelists, so I want to echo what they said, that in the pandemic, the greater use of telehealth, we have seen little evidence or no evidence that it has hurt quality of care. So I think it's a positive that we can go back to the American public and say, look, this expansion really did improve the health of Americans.
Okay, good. Thank you, Mr. Chairman.